Thank you for this opportunity. Thank you to IHF. And we apologize for coming to you virtually. We sure all wish we could be there live, enjoying the conversation and networking that's happening there in Barcelona. We are going to bring you a session about avoiding the pitfalls and traps in global health, and talk to you about networking and the opportunities that are available there. We're now going to play the video, and we will be back afterwards to hear your comments and answer any questions. Thank you all.
Hello, and welcome to this session. In this session, presenters with global health experience, combined with extensive experience in health associations, corporate work, academia, and standards and accreditation, will discuss the nexus that brings us together and opportunities for collaboration to strengthen local health systems through capacity building. This session will highlight how the four presenters combined interest in improving the impact for patients globally. Through a moderated conversation and presentations, the presenters will discuss how research, assessments, partnerships, mentoring, and technology have both individually and collectively work to improve the quality and safety for patients in low and middle income countries. I'm Bruce Compton. I'm the Senior Director for Global Health at the Catholic Health Association of the United States. We are a voluntary member association, which is made up of nearly 600 hospitals, 1,500 long-term care facilities, thousands of clinics, and over 750,000 employees of Catholic healthcare in the United States. Those members care for 1 in 7 patients in the United States that is cared for daily. My role at CHA is to work with our members who are doing global health activities. And we do that through 5 primary methods. We do research on behalf about global health activities to learn best practices. We take that research and we turn it into educational tools and resources. We do collaborative projects with our members and their partners, and we work to connect them to do other collaborative projects. We work in consultation with our members who are either starting or revamping global programs. And finally, we do networking. And it is through the networking that I met the people you'll meet today that I will introduce you to and the programs that they're working on to strengthen global health through capacity building. As we do that, I'm happy to highlight how CHA helped to connect and to work with each of these. And I really look forward to hearing your questions when the presentations are finished. So we shall go ahead and get started. Our first presenter is Myron Aldrink. Myron is the chair of both the Medical and Surgical Skills Institute and Advocacy for Global Health Partnerships. Myron comes with extensive corporate background, including being the president of Asia and opening the China market for Herman Miller. Myron will discuss how MSSI in Accra, Ghana trains healthcare professionals in modern healthcare techniques and technology aimed at delivering improved healthcare service at a world-class standard. In addition, he will highlight how AGHP, a consortium of partners with significant experience in global health, are working together to emphasize the importance of appropriate ethical, legal, and regulatory standards in short-term health engagements. Myron, the floor is yours.
Thanks, Bruce, and thanks for that very kind introduction. Yes, I do have a very unique mix of both corporate and NGO background, and very happy today to be discussing the MSSI, the Medical and Surgical Skills Training in Africa, and also AGHP, Advocacy for Global Health for medical missions. And I like to tell stories about the evolution of these 2 programs. And so let's start with the MSSI. But leading into that, I'd also like to tell a personal story of my own evolution. While I was a corporate executive with Herman Miller in China, my children developed respiratory problems. And so I was forced with the choice, do I remain president of Herman Miller Asia, or do my children breathe? Fortunately, I made the right decision on that and decided to, resign and came back to the States. But when I came back to the States, I kind of felt a calling for global health rather than, building another new office furniture chair or whatever. So I switched from the corporate life and joined a local NGO, a medical NGO, which focused on medical equipment. Well, with that NGO, Johnson & Johnson recognized my corporate background and liked the fact that I could speak their jargon, their business jargon, also that I knew ROI and all those things. So they asked me if they would, if I would help them start medical training in Africa. So in 2005, we came to Ghana, West Africa, and took an old animal lab at the Korle-Bu Teaching Hospital and renovated it and made it into modern surgical suites. And then what we did is we brought in specialists from the US and Europe to provide surgical training to the local doctors there. And these were doctors from places such as Harvard, the Mayo Clinic, Royal College of Surgeons, Tübingen in Germany, Strasbourg. And so in 2005, we trained 18 African surgeons. The next year we got up to 31. The following year we trained 61, and in 2008 we ended up training 92 surgeons. While this surgical training was successful, the MSSI realized that we were really not having a major impact on the health or strengthening the healthcare system. So we decided to have three major changes. The first change is that we switched from just training the surgical specialists to training the other groups that work with the surgeons, nurses, anesthesiologists, and all the people that support the whole surgical ecosystem. The second change we had is we switched from an NGO model to a surgical, to more of a social business model. And by that, we worked with both the government, hospitals, and the corporations in a manner to where each of them provided things, but they got out more than they put in to make it sustainable. The third change, and probably the most important change, is we switched from bringing in experts from the US and Europe to training local doctors and having them do the training. And there's a great number of quality doctors in Africa who made extremely good trainers. And this was good for a number of reasons. In addition to be cost effective, the local doctors knew the needs and the diseases in the area. They could better relate to the people in the area, and was much more sustainable. They were there permanently rather than just in and out. So that all worked extremely well. And the MSSI grew from, like I mentioned, we trained 92 surgeons in 2008. Well, 6 years later, we were training 3,000 medical professionals across Africa. 5 years later, in 2019, we were training almost 10,000 medical professionals across Africa. Well, then in 2020, with COVID hitting, we then added on online training. And with online training, we grew to training 33,000 medical professionals across Africa, impacting 27 million patients. And the MSSI had now become the leading training center in Africa and was recognized twice by the UN for thought leadership. And the success to the MSSI is really in that we stopped thinking like a traditional NGO and taking on a partnership approach, and working and focusing on sustainability with local trainers. While in Ghana, I saw a lot of US and European people come in to do medical missions. And by medical missions, I mean where a doctor or nurse would take 1 or 2 weeks off of their practice and volunteer to come to a country and provide medical services for people in needs. These people, volunteers were wonderful, they had a heart for compassion, and they really did good. However, there were problems with this whole medical mission approach. For example, sometimes they did not know the local medicines in the area, or the nutritional or food values. They also didn't know the local healthcare system. And sometimes the services they provided were not aligned with the Minister of Health's priority. Sometimes they also had a lack of cultural sensitivity, which kind of undermined the local doctors and the local healthcare. So those are the kind of issues. Well, this all came to fruition when in 2016, Medtronics, a large U.S. medical equipment company, came to me and asked if I would review their product donation policy, in particular regarding medical missions. So I said, yeah, I'll be glad to do that. So what I did is spent the first year doing research and studying and better understanding the whole area of medical missions. And when doing this, I also did a literature review, and I realized that certain names kept coming up, whether it's Dr. Martin Nuke in Australia, Paul Cadron, in the Netherlands, or Dr. Judith Lasker in Lehigh. So I reached out to these people, and when talking to Judy Lasker, she said, hey, would you be willing to help me provide corporate input into a presentation I have to the CUGH conference coming up in 2017 in Washington, D.C. And I said, yeah, I'll be glad to do that. And then when talking to Judy, we realized that most of these people that we around the world in medical missions, those names that keep popping up, we're going to be at this conference. So we decided to have a side room and invite the people and talk to them about medical missions and see what their thoughts were on that. So we invited 18 people, and these people came from all different backgrounds in different sectors. We had people from the government, we had people from hospitals, faith-based organizations, corporations, universities, from both the sending countries and the host countries. So based on that, 4 people took the lead in this. And the 4 people were Bruce Compton and Shiley, who are on the panel, and also Judy Lasker and myself. So this group of 4 spent 3 years studying, the issues. And we, at the end of 3 years, we realized that, the problems are real, and complex. And the host country is really not leading the way. And there's a real need to establish, global principles. At the same time, we also did in-country research with countries such as Ghana, Uganda, and Guatemala. And this is probably the first time that this topic was, research was conducted from the in-country perspective. So, but based on all this, we decided to have a summit in Geneva in 2020. And we were going to have this at the Brochure Foundation. So we invited people from around the world from the different sectors and global health leaders to get together in Geneva and talk about medical missions. And unfortunately, the conference got canceled due to COVID. However, we continue to have discussions with these people. And based on the discussion, it was really decided that we should have a global declaration regarding principles in this area. And Shiley, who you'll hear shortly, was the author of what became the Brochure Declaration. And the Brochure Declaration has 6 key principles. And I would like to read these principles. The first principle is mutual partnership and bidirectional learning and input. And that's where both sides, the host and the sending, learn from each other. Number two is empowering the host country. And the community defines the needs and activities, not what the sending organization wants to train. The third one is sustainable programs and capacity building, not short-term efforts, but long-term sustainability to improve the healthcare system. The fourth is compliance with applicable laws, ethical standards, and code of conducts. All this is based on the number 5 principle, which is everyone should come with humility, cultural sensitivity, and respect for all. And the last one is accountability for actions. All these programs should be evaluated, and the accountability for impact on health should be measured. Well, since 2020, AGHP has been very active, and the brochure declaration has been widely accepted and endorsed by more than 40 global organizations, including International Hospital Federation. So in conclusion, I would first like to thank IHF for inviting us to speak today and able to share the brochure declaration, and also the opportunity to advocate for the importance of ethical, legal, and regulatory standards in short-term health engagements.
Thanks, Myron. As you all can see, Myron's extensive experience has been valuable to CHA, not only because he and MSSI are helping to train so many people across Africa that our members will then work with. Myron has also assisted some of our members to make connections in countries where he has worked in the past. And of course, Myron mentioned that we are working together with Advocacy for Global Health Partnerships to really strengthen those short-term engagements in global health and institutional partnerships. We will now transition to Joyce Chang. Joyce is from the Joint Commission and will highlight JCI Navigator, an online solution designed to work with hospitals who have yet to start or just starting their quality journey. This integrated solution facilitates a practical and progressive approach to build a roadmap for continuous quality and patient safety improvement. So Joyce is the Director for Joint Commission International at JCI Navigator. Prior to joining JCI, she focused on government and business financing, as well as within the Greater China market as a strategic account manager for Philips Medical Systems. Joyce, it's wonderful to have you with us here today. We look forward to hearing your remarks. Thank you.
Thank you so much, Bruce, and thank you. So, hi, my name is Joyce Chang Price, and I'd like to thank Bruce at CHA and IHF for the opportunity to represent JCI and participate in this panel. So as a part of this panel discussion, what I'd like to share is some of JCI's Joint Commission's recent work on quality and patient safety, and some of it's in collaboration with partners of Catholic Health Association. So first, a little bit about Joint Commission International. JCI is a not-for-profit organization based near Chicago in the United States. With that said, we are an international organization, and as the international arm of the US Joint Commission, our mission is to focus on the improvement of patient safety and quality of care, specifically in the international community. And we do this by offering a couple services, such as education, we hone in on publication, we provide advisory services, and most importantly, what we're known for is our international accreditation business. Now, we're very grateful to say that given our active work in the international community in the past 20 plus years, we're often recognized and known as the gold standard in patient safety and quality of care, most likely known for, like I said, in our international accreditation work. Now, in the 20 years of working in quality and patient safety, we've seen quality and patient safety truly escalate from what traditionally is more so of an issue, a topic of discussion in the more well-resourced countries, such as UAE or Singapore. But now it's kind of transcended across and become an issue, a problem, a challenge in the resource constrained parts of the world as well. Now, in the past, attention in global health tend to focus on access to care. However, in recent years, data has really started to show us that poor quality care is now a bigger barrier to reducing mortality than insufficient access. So while patients may have access to care, the care that they're receiving may actually be causing them direct harm. And with that said, I don't think JCI or any of our staff have ever met any organization who doesn't think patient safety and quality of care is not important. In the hundreds of hospitals and leaders that the JCI team has spoken to, almost everyone would agree that patient safety must be a priority. It must be a goal that we all strive towards. The challenge really comes down to the hospitals and their staff understanding what does quality and patient safety look like in their hospital. How is it translated from this concept, an abstract concept, to their day-to-day work? And if they do, in fact, make that connection, then the next question is, well, what do I work on? What area should I focus my improvement on? Because once you start seeing the risk that exists, you start to see it everywhere. So what areas should they prioritize that will allow them to generate the greatest returns when it comes to improvement? And finally, if they do implement some improvements, what does that improved state look like? What does better look like? And how will staff know that the actions or the improvements they've made have actually resulted in positive patient outcomes? Now, other than these common challenges, JCI has observed some key positive attributes that we see amongst high quality and safe organizations that we think is good to share as some lessons learned, as benchmarks. Now, organizations who are able to provide safe care to their patients tend to embrace a more systematic approach to quality and patient safety, meaning in order to achieve a positive patient outcome, you can't depend on just one single practice or one individual. This is something I think Myron in the earlier discussion had touched on as well. But rather, it's important to understand the interdependencies between systems and subsystems of care and how they work together. Another key attribute that we have observed is the focus on critical thinking. Success and quality tend to be more sustained if the staff involved and the leaders involved are encouraged to think critically and problem solve on their own, rather than relying on an external individual or a team to come in and say, here's your problem, and we're going to fix that problem for you. So without that local team understanding the whys and the hows in terms of how it applies in their local context, that quality improvement work will likely cease and drop as soon as that external intervention leaves, which is obviously not sustainable. And that leads to the last concept of ownership. In our experience, quality can only truly be ignited. It's the real deal and sustained if the leadership and staff feels a true sense of ownership in that work that they do. Every time when we hear leadership, hospital leadership and staff, when they say they're proud of the work that they do and they feel a true attachment to the care that they provide, that's when we know that motivation is real, and it's most likely that that interest to improve will come to life and be sustained going forward. So having observed and witnessed all of these challenges and the success factors, we realize that there is an opportunity for JCI to contribute. So therefore, our passion for our mission has led us to recently refine our direction and goal, which is that we see our goal is to help organizations demystify that quality and patient safety journey, and to provide them with the necessary tools and resources and help them remove barriers such as financial obstacles or talent constraints, so that organizations at any maturity level can take progressive steps to achieve safer patient care. So this goal has led us to the development of JCI Navigator, which is a patient safety improvement tool, most directed to hospitals who have yet to start or are just starting their quality journey. The Navigator is an online solution, so anyone who has access to internet can, have access to this solution, even from their phone. And it's really designed to help organizations self-assess, to really help build that self-driven approach, that ownership. Their response, is not someone else coming in, and to learn and improve their quality and patient safety maturity. There are 3 components that are built within the Navigator. And it's really designed based on the existing improvement science and principles, like the MAIC. So at first, we feel like if any organization would really like to improve, the first thing they really need to do is to determine where the current status is, understand what their strengths and their weaknesses are so that they can hone in on the appropriate area to improve. Now, this is done by, we ask organizations to complete an online organization-wide self-assessment. After a hospital can understand where they are, know what area they should be focusing on in order to improve areas of the highest risk. This is when the questions start to pop up. Well, how do I improve, right? How do I develop interventions that will address these issues? So this is where we will connect them to the second component, which is Educate, an online library that's been curated by JCI with more than 600 resources to help hospitals learn about all the different improvement options. Now, once the hospital and staff has an understanding of some of the improvement work that could be done, then it comes time to sit down and think critically about formulating a plan that will work best for their hospital. And this is where you want to connect that hospital with someone who have experience, so that, and this is where we connect them to a JCI expert to provide virtual ongoing support. And the idea is really that someone with experience to come in to become a coach or a mentor to that hospital, to help them think through things, to guide them, but not to do the work for them, and to perhaps share their experience so that they can, avoid the unnecessary obstacles and make sure that they chose the appropriate path going forward. The Navigator framework is based on JCI's widely accepted international standards. And this is where you see for our framework, we see quality as almost like a puzzle, a system and of interlaced relationship, where all these essential key pieces need to be in place in order for a hospital to truly tackle quality and safety in a very constructive manner. So this international framework is really designed to help hospitals make sure that they have the right structures, to help them build the structures, and to make sure that they have the appropriate processes in place in order to ensure that outcomes could be improved. So here are some examples how the Navigator has ignited interest and really helped hospitals get started in their improvement journey. The first example I'd like to share is a hospital based in Nigeria. This hospital has recently formed a TQM team, a total quality management team. Now, other than the generic patient wait time project, this team had really struggled to find a patient safety project that they can dive into. So the team member came across Navigator online. With that team, they worked together to complete the basic version of the Navigator assessment. And the results here has helped them identify some areas in their hospital that they might want to take that are high risk for patients and staff. So for example, infection prevention control, looking into their hand hygiene, barrier precaution isolation, their cleaning, disinfection, sterilization practices. How are they reporting patient safety events? And from a facility environment of care perspective, do they have fire safety process measures in place and how they manage their utilities? So this is from there, the team had taken an interest into fire safety, understanding how catastrophic it would be if an incident did occur. So this is where they dove a little further in to learn about some of the critical concepts that are involved in fire safety. So for example, it's crucial to have a program in place. And from there, you also need to think about what equipments do you have access to. Training is critical because you could have the best program and equipment, but if staff are not trained, they're not going to know how to react or how to use this equipment when a fire does occur. And finally, the evaluation of that program to ensure that staff, that their practices and the policies they have are current and up to date and the equipments are working. So the next question for the team is they understand what's important. So the next question really was, well, if we want to improve, if we want to build a program, if we want to know what equipments we need to have, if we want to build a training plan, we want to evaluate how to do that. So this is where they moved onwards to the Educate component, the online library, and they found the necessary resources to help them bring these concepts to life and for them to act on these improvements immediately. So for example, a sample policy and procedure of what a good fire program safety look like. They can look at it, understand what it should be, and pull those information to see what a program should look like in their respective context. Or for example, a checklist. Checklist was some of the more critical questions that the staff should be asking if they want to check if, the doors and hallway egress assessment, is in place. Finally, I'd like to share how my last example is how the Navigator as a tool can enable partners in health to further advance their efforts in safe patient care. So Missio Invest, the organization I'm talking about, is an investment vehicle which is created by the Pontifical Mission Societies in the United States. The focus of Missio Invest is to strengthen crucial services in sub-Saharan Africa, such as healthcare. Missio decided to highlight their commitment to quality by asking their recent healthcare investment ventures to complete the Navigator assessment as a condition of their loan. And the intention is not so much of asking them to be at a specific quality level, but more so communicating the language, communicating that quality is on the agenda, it is important, and that quality they are expecting the hospital to make improvements over time. Not so much at a specific state, but the hope is that continuous improvements could be made over the lifetime of the loan. So to us, this is a great example of how a partner in health could use their influence in their role to ensure not only access to care, but access to safe and high quality patient care. So with that, I'd just like to thank you once again for your time and attention and the opportunity to share JCI's recent work and partnership in the space of quality and safety. Please feel free to contact me if you have any questions, and I look forward to your questions.
Thanks, Joyce. That was a great example of how your tool can assist hospitals and health systems in improving their patient and quality journey. I really appreciate highlighting Missio Invest. CHA has as one of our strategic goals to improve church relations and to build church relations. Missio Invest came, as you said, from the Society for the Propagation of the Faith, which is an official papal agency. We are collaborating with them, and we have members also working, providing insights about some of those loans. So the fact that you're working with them is just another great example of how networking and using the collaborations that we have built through Catholic Health Association's Global Health assists the church and hopefully in the end, those that we care for, the men and women in need of care. It is now my opportunity to move on to the next speaker, Shaili Prasad. Shaili will provide insights into how through collaborative partnerships, sustainable programs, and academic excellence, the University of Minnesota and the Center for Global Health works to create a world where equitable health worldwide aren't just a vision, but they become a reality. Shaili is caring for patients and teaching the future leaders of healthcare and providers of healthcare around the world. So Shaili is a family physician and the executive director of the Executive Director and Carlson Chair of Global Health at the University of Minnesota. In addition, Shaili is the Vice Chair for Education in Family Medicine and Community Health. He's an adjunct professor at the School of Public Health and serves as the faculty lead for the Rothenberger Leadership Academy within the University of Minnesota School of Medicine. He is also a visiting professor at the University of Cape Town, South Africa, and Udiana University in Bali. Shaili also serves on the committee, as Myron mentioned earlier, with Advocacy for Global Health Partnerships, AGHP. Shaili, it's great to have you with us today, and we look forward to hearing your presentation.
Thank you, Bruce. Thank you for this opportunity to share some of my perspectives. When you asked me to look back at some of the partnerships we've done, and particularly look at the traps that we fall into when we do these partnerships, I was reminded of some of the roles we play in global health. And that got me thinking about my journey into where I am today. I started my life as a community organizer, working amongst remote and tribal areas in India. And subsequent to that, over the past 30 plus years, I've worked primarily in underserved areas. And in these areas, one of the things that has struck me is that there are a lot of good intentions, which is good, don't get me wrong, but the good intentions don't always translate into effective work. Like Bruce mentioned, I lead the Center for Global Health, but it's also called the Center for Global Health and Social Responsibility. And over the past many years, I've been mulling over what that social responsibility means. And hopefully today we can talk a little bit about what that would translate to. And to begin with, observing various organizations doing work in global health, it always struck me that academic institutions come in with a lot of promise, including the University of Minnesota for that matter, but it doesn't always translate into effective work. It brings up the question as the role that academic institutions play in global health. We can make a case that a lot of academic institutions don't do a great job in their own neighborhoods. So then the question comes up, how does that then translate across seas to other countries, to other partnerships? Primarily, we think about academic institutions being at the forefront of research about creating new knowledge, exploring new paradigms, and from there onwards, building capacity. If that is the premise in which we start, we have to recognize that that doesn't always translate well, primarily because the approach might be hamstrung by project-driven goals. So what does that mean? Well, I try to look at partnerships along three axes, if you will. The first being a project-driven axis, strong indicators, outcomes drive the work. And don't get me wrong, project-driven work is something that all of us do, and it's important because we need to have tangible benefits that our work does. That is one approach. The second approach is a process-driven one, which tends to be much longer term, which tends to look at it as an ongoing partnership model. I'm here to suggest that there is a third one, and the third one should form the basis of the project and the process-driven work. And the third one is a relationship-driven one. And I'm not trying to say that, we should all reject a project or a process-driven approach towards a relationship-driven one. I'm here to suggest that a relationship-driven one should be the basis of a lot of our project and process-driven work. It's only then we can actually understand the impact that we do, that we go beyond the outputs that we aim, and recognize the potentially untoward, unwanted byproducts of the work that we're doing. Quite often when we are very much honed into an output-driven, project-driven approach, we tend to either neglect or willfully forget that there are untoward consequences. And the field of healthcare is replete with examples of untoward complications, untoward issues, because we have not kept our eye on it. So with that, I'd like to, for a minute, take a step back and talk about global health primarily as different eras. And I'm doing this because we are in the midst of a huge era, and I would like to call it the COVID era, not a post-COVID era. I don't know what post-COVID means anymore. I'm going to say it's the COVID era. COVID has been a huge stress test to systems around the world, and generally systems have not done well. So stepping back, I like to look at global health as three eras. The first era, Global Health 1.0, is predominantly in the 19th century, a spirit of adventure, conquering new places, finding new diseases, sometimes naming it after yourself, and then coming up with the exotic, adventurous aspect of global health. That transition to Global Health 2.0 is the predominant model of the 20th century, and one can make a case still prevails today. It's about solidarity. It's about recognizing what the problem is and trying to step in. A challenge with that is also that we tend to step in from a very medical, clinical aspect. The growth of Global Health 2.0 can be summated as the era of biomedical reductionism. And don't get me wrong, clinical care is very important, biomedical care is very important. I'm a clinician by training. But while we are at that, we have to recognize that the biomedical approaches towards global health partnerships probably help at about 10% of the overall healthcare of a community. We have a huge component of the social determinants of health, the commercial and political determinants of health that influence the overall health of communities. So while Global Health 2.0 has been a predominant model of multilateral support, of solidarity, of large institutions taking a lead in global health activities, they've been primarily hampered by an approach that has been looking at a biomedical model. I would also like to make a case here that for the next phase, which I'm hoping that the COVID era will start a new phase, we have to understand that some of the things that from the past, including the solidarity, understanding people, etc., is very important. We need to embark on new models where we respect each other. So if there is one byline I'd like to suggest as the next phase of global health, I would say it is the phase where we learn from and with each other. The learning being the key part here, because it's in that learning that we form the solidarity, the work, and also recognize that the problems that we're facing in global health are extremely complex, and no single entity can deem to have the answers to all, that we need to share know-how, knowledge, and then work towards capacity building in that. So if that is the overall philosophy of what this new era should be, I'd like to reflect on some of the examples that I've seen and some of the challenges that they've brought up and some of the good lessons that they've created. While I took over as the director of the center that Bruce mentioned here at the University of Minnesota, I wanted to know the history behind it. And as I was going through some of the historical archives here at the University of Minnesota, I stumbled across what was then called the Minnesota Project. And please understand, I'm not doing this because I want to brag a little bit about Minnesota, or maybe I am. But I want to use that as an example to talk about a project that took place in the 1950s. It was a 6-year project between 1955 and 1961, where the University of Minnesota collaborated with Seoul National University in South Korea to help develop systems of care, particularly in healthcare, particularly in clinical care. And that project led to a lot of exchange of ideas, a lot of folks from Seoul National University coming to the University of Minnesota to train, and a lot of people from the University of Minnesota going to Seoul National University and training folks. Today, that has been attributed to be an important inflection point in the growth of modern healthcare in South Korea. I think it will be naive on my part to say that that was the reason why healthcare and health in general has improved in South Korea. I know we are given a lot of credit, and thankfully, Seoul National University is extremely graceful in attributing a lot of that to us. I would like to say that what really happened in South Korea was an overall development, economic development that spurred more activity, where this inflection point was one point in an overall set of things that happened to improve the health and healthcare there. So the lesson then is, yes, clinical care is important, sharing know-how is important, capacity building is extremely important, but they cannot live in isolation. Because there are other examples where we at the University of Minnesota have partnered with other countries, other institutions, other entities, but it's not translated to the same level of success. So while we might take credit for the successes of a Seoul National University, we need to be humble in recognizing that that is one part of an overall set of things that we need to be doing. So that brings up the question, what then should be the philosophy in partnerships? Bruce has heard me say this, Myron has heard me say this. I like to approach it, our center likes to approach it based on 3 statements. And I hopefully will convey the ideas behind those statements as a test, if you will, of creating partnerships. The first one is a statement that says doing the right thing. The second one, doing the thing right. And the third one, the right person doing it. What I mean by those is that the first statement, doing the right thing, should really look at the philosophy, the ethics of the work that's being done. That should be the guiding principle. That should be the true north, if you will, that directs us to the work that we are doing. It should make us ask the question, why are we doing this? What is the baggage we bring? All of us do bring our own baggage to any partnership that we enter into. What is the baggage that we bring in creating the partnerships? The second part, doing the thing right, is it's not just the good intentions that matter. Good intentions are very important, but how you do the work, the science, the methodology, the steps that you need to do it appropriately is critical. The third statement is the right person doing it. And I can tell you quite often, academia is probably the last group to do things. We might be fantastic in some aspects, in running a research trial, for example, or coming up with a philosophy behind things. But in implementation, we are not that good. I lean on a lot of my colleagues from NGO movements, from business, and other groups who have more lived experience in implementing projects, rather than us saying, hey, we should be the one doing this. So if these 3 are the guiding statements, anchoring statements that we live by, we should then ask ourselves a question, whenever an opportunity comes our way, are we really holding ourselves to those 3 statements? Thank you.
Thanks, Shaili. What a great presentation and an opportunity for us to really think about how do we learn from and with our partners. Shaili really does embody that statement. I've been lucky to work with Shaili, Myron, and Joyce over the last years. And I'm really happy to say that as I came on to the Catholic Health Association 11 years ago to begin our global health programs, we have done several research projects, as I mentioned earlier. And those research projects didn't always uncover great results, great projects. There were things that were embarrassing. There were times when our communications department said, we're not going to tell people what we found out in that research. But by finding partners like Myron, Joyce, and Shaili, CHA has taken that research, developed educational opportunities, continued to network and build relationships both with people here in the United States and with partners around the world, so that we can help our members and their partners improve the impact of the work that they're doing to assist poor and vulnerable people around the world. That is really something that Shaili, a continuation of something that Shaili referred to in the early stages of Healthcare 101. It was global health. It was sisters who left Europe and came to the United States in the late 1700s and the 1800s that developed the healthcare here, helped to develop the healthcare here in the United States that make up those statistics that I talked about earlier, where we have 600 Catholic hospitals, 1,500 long-term care facilities, and 1 in 7 patients is cared for. What we've learned together and what we continue to do to reach out to assist others, we hope to do in ways that improves the healthcare. And CHA has been, as I already said, so lucky to work with this group of people as we have as we have continued the work started by those sisters in that 1.0 version. Thank you all for your presentations, and we look forward to continuing the conversation.
Thank you again, everyone, for your attention during those presentations. Thanks again to Shiley, Joyce, and Myron. I did not see any questions in the Q&A, so I am going to just offer each of you the opportunity to provide any final remarks and maybe one lesson learned that you already share or that you will share moving forward based on what you've heard from others today. And we'll start with you, Joyce.
Thank you so much, Bruce. If I may, just a couple of lessons learned. I think under the theme of partnership, just a couple of tangible concepts from our end. One is that, we really just need to be humble and to realize, how we need to work with all the different stakeholders so that we can generate a positive outcome to work with partners. And second, through that, to push for a more sustainable approach by thinking systematically, thinking critically, encourage others to do the same as well. And finally, just to make decisions based on data. Thank you.
Wonderful. Thank you so much for those. Shiley, the same question to you. Anything, a lesson learned or any final remarks for today?
Bruce, my quick response would be what Joyce said, because I think she put it beautifully by saying that we need to be humble in our approach towards this. I also bring up the point that every encounter with a partner, every partnership is a learning opportunity. COVID has taught us that a lot of our preconceived opinions about what we do is going to be completely upended. So we need to be ready to be doing the new learning as we go forward. And I sincerely wish that every partnership is based on that curiosity of new learning that we do, combined with what Joyce mentioned, the humility that we need to bring into this. So thank you for that.
Thank you, Shiley. Myron, over to you again for any final remarks and a lesson learned that you might take forward from today.
Thanks, Bruce. Yeah, the whole concept and the sort of a thread throughout all the presentations today is, in fact, global partnership. And as Shiley said, respect for others, learning, and most importantly, what Joyce said, and actually what Shiley just echoed, is humility. We got to enter this in a humble way, and that's sort of a key component in that ongoing global debate right now on decolonization. How do we provide equity and support, not abandoning, countries, but supporting them in a way that's beneficial to everyone involved, but done in respect, culturally, sensitivity, and again, the key point of humility. Humility is what the world really needs right now. So, thanks, Bruce.
Yeah. Once again, thank you all. I really do believe that what we've heard today is very related to the networking and the opportunities of collaboration have brought to CHA, the value that's brought to us as an organization and to our members who use the resources that are brought to the table. I guess my takeaway is that AGHP, JCI, and the work that you do with MSSI and the University of Minnesota, as well as what CHA, it appears to be on the right track. But as you all said, we need to continue to think about being humble as we go about this and developing those partnerships in a way that really is respectful and sustainable. And to that end, I think I'll close by saying that that's sort of what I said at the beginning when I talked about what CHA, and I think that's what we all are trying to do. And we're pulling together, another conference where we're really trying to, in Geneva next year, as part of AGHP, where we're trying to identify the impact of those partnerships, where we're trying to, as AGHP, really develop that bridge between the partners in countries and their global health counterparts, and to create a framework for representing leaders from the various sectors with a real emphasis on that in-country perspective so that we can be humble, so that we can really listen from the right. And we hope to create a sustainable business model that continues to help those kind of relationships, these partnerships, continue to improve into the future. I think these will be important to both hospitals here, in high-income countries as well as low and middle-income countries. And I think getting that voice and those opportunities is an important part. We are so thankful to have had the opportunity to voice these things today, and thank you for your attention.